Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, founder of Coaches Club, author at philplisky.com, and a performance systems consultant in professional sports. Being a physical therapist, athletic trainer, and strength and conditioning specialist, we come at this from multiple different angles. We dive into the research, but more importantly than just looking at the research, we want this to be applicable to you so that you can implement it in your setting immediately. I'm looking forward to our topic today, strength testing and electrical stimulation after ACL reconstruction. I'm excited to be joined by our guest today, Dr. Lynn Snyder-Mackler. She has been on our podcast before. She has a tremendous amount of experience, 45 plus years treating athletes with traumatic knee injuries, and her research really has been pivotal in our profession. Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Welcome to the podcast, Lynn.
Thank you. Happy to be here.
No, it's so great. We had such a great conversation last time, and I think we hopefully provided some good clarity on the open kinetic chain debate and why it's really not a matter of even a question of if it's safe or not, but how essential it is in order for that. Could you give us a little bit of background, just so that if you haven't listened to the episode, which I highly recommend you go back and listen to, but if you haven't and just want to continue on this episode, let's give us a little bit of maybe a summary, a high-level view of that last episode.
Yeah, so we talked about how important the quads are in recovery, not just from ACL, but any intra-articular knee injury or disease. There's just a constellation of things, symptoms, and movement changes that happen with this, with the joint, the knee joint, and the quad. Um, so we we talked about how important that was, and I think we're going to get to right now is about how important measuring quad strength is to be able to figure out whether, in fact, what you're the interventions that you're implementing are actually working. Right?
Right. Well, and I think that's a huge point that I really liked that was made in the last episode was, we almost don't care about what specific interventions you're doing. And I think this was a message that you don't really care about what specific interventions you're doing, but as long as you're getting the outcomes that you need, and outcomes and measurements aren't just defined by the patient or the athlete is feeling well, we have other outcomes, and we start talking about. I'm seeing that measurement of strength in a whole lot of aspects of rehabilitation,
Mhm.
but particularly post-operatively, seems to be a little lacking. Why does it matter?
Well, you really have no idea whether your strengthening interventions are having an effect if you don't measure. So, two of the giants, for Eugene Michaels, who was a professor at Penn, but also the first head of research at APTA, and then Jules Rothstein, who was the editor of the PT Journal. It was like, if you don't measure it, it must not be important to you.
I love that. Let's
So,
let's let's linger on that a little bit. So if you're not measuring, in the business world, I've done a lot of
yeah,
management and executive training. In the business world, we say, what if you don't measure it, it's not going to improve. If you don't monitor it, and if you don't give feedback of that measurement, it's
correct,
definitely not going to improve. So if you don't measure it, it almost doesn't exist in your world.
correct, absolutely. So, it's it, look, we can talk about how important the quads are, and it's really unequivocal with interarticular knee disease or injury that quad recovery is critical to normal movement. It's critical to preventing downstream secondary prevention, really, of of other injuries, including second traumatic knee injury. So it's a really important to do. And we have to be able to measure. And really, the problem with doing anything other than an open chain test, isometric, isokinetic, isotonic, doesn't really matter, is if you it once you start doing something that involves the all the other joints, so a closed chain test, you have no idea. Unless you
Let's
unless you got EMG electrodes, so you see, but I can do a unilateral leg press without
Mhm.
I can quiet my quads, not use my quads at all. So,
And the research bears that out
yeah,
really strongly that
really strongly.
in several different areas, all the way from unilateral leg press, and again, I don't necessarily wanna say that that's not a good measure, but it's not a good measure of quad strength, right?
It's
It
right, and it's not a good the one of I mean, you know this from strength and conditioning, like, you can't put somebody start with, like, a basic exercise, like a push back with a knee extension, foot on the floor with a some kind of band, right? Um, unless you're watching, putting your fingers on the patella, you don't even know if the quad I can do those too forever, only using my glutes, right?
Right,
I mean, so so s when I see somebody doing those or on a leg press machine and there's nobody around is watching them, they don't know. It's so easy, and kids are great at compensating because that's what they do. They're not it's not that they're avoiding it, they're just you told them what to do, they're gonna do it, and that it is an effective quad exercise unless you're sure you're activating the quads.
well, and
No.
I think that's the key message there is, the way our bodies are designed is amazing in that we have tremendous amounts of redundancy so that if any nerve, any muscle really in the body gets cut, we have things that can make up for it, and I think that's what happens after a knee injury.
So, in the lower extremity, I would agree with you. In the upper extremity, it's a little bit of a different ballgame.
Certainly, we have a different
It's smaller
yeah,
muscles. They also have different smaller muscles,
different functions. It's a
deltoid
different function, yeah,
you know, deltoid and larger are controlled neuromuscularly in terms of recruitment and rate coding in terms of how they force differently from the smaller muscles,
for
um,
sure.
that use a lot of rate coding so they can be very precise, right?
Right, absolutely. Well,
Um,
yeah,
but
when we're talking large movements, there's a lot of different ways to do it.
in the especially well, and this will segue us into strength training, strength testing. In the lower extremity, you have a lot of biarticular muscles
Mhm.
that can have a secondary effect on their joint that's not their primary mover, right? And the knee is great when your knee is sick, you can displace those forces, transfer the motor control to the hip and the ankle, and do pretty well.
Well, as a matter of fact, not only does it go from, walking and a leg press and things like
Mhm.
that, all those things, it all the way goes to vertical jumping, single leg
Yeah,
vertical
yeah,
jumping. It you can have equality in hop testing, and equality in single leg vertical jump and not necessarily even, know that you're getting, the quad strength you need. Now, single leg vertical jump is more quad dominant than maybe a hop
yeah.
test, but it's still not isolating it.
It's still a hop, it's just up
Right,
rather
it's a vertical hop.
yeah,
Yeah.
but, I think it's still our goal we have a therapeutic goal, after an ACL injury and or reconstructive surgery, that getting quad strength back is imperative. So, range of motion, decrease of fusion, get the quad strength back. That's your base, right? So we have to make sure we're doing that. And so again, there are lots of ways to monitor it if you're doing these closed chain exercises. You could put a EMG biofeedback. There are lots of devices. M Trigger is one that's probably most common, common one to use in the clinic. No, I'm not a paid consultant for them or anything. But I think um, you you really, really have to be careful and think about what you're doing.
So if we look at this and we say, all right, the the 5 RM single leg press is probably not the way we need to be measuring quad strength. And second, for probably first of all, we need to be measuring quad strength in an isolated way. The leg press is not the way to do that. And so then what are our options to be able to do this? Because
Sure.
we talked about a little bit in the last episode, in my utter disappointment, we only I'm in a large city, maybe I think maybe the 3rd
Mhm.
largest city in the state of Indiana, and we used to have, it's dwindled over time, but we used to have 2 groups that had, isokinetics, strength testing machines, and, now we're that has dwindled to really 1. So when I'm looking to refer out, for a patient, it's now the options are decreased. But with that said, what are our options there? And we have gold standard, and we have maybe things that are good enough. What would you say there?
So, Phil, you have a knee extension machine in your shop, right?
Yes. Yep.
Yeah. There, believe it or not, I have students calling me saying they're in a rotation where they're seeing ACL injuries and all they have are bag weights. Okay. Again, there's a great article from a while ago now. Anthony Senecor is the J.A. Senecor is the lead author from, he was doing um, his PT at Pitt, and it was in JOSPT, and they compared the gold standard was isokinetic dynamometry. They did leg press. They did um, knee knee extension on a knee extension machine with limited range, truncated range, or full range. What was the last one? What am I missing? In any case, um, the gold standard was absolutely closely approximated by a 1 RM on a knee extension machine. So you don't
Right.
really have to send your patients to get isokinetic.
You don't, but that quantification
It does
is,
help. The
what I
price
use.
tagging.
Yeah, what I use, the knee extension machine for, like, I almost kinda somewhat,
Right.
think of it as 2 different things, is I can give the patient a goal when they're away from me, right? So,
Yeah.
here's your max rep goal,
Yeah.
and that should be improving, and you can look at it compared to the other side,
Well, that's
and we
another
can
way of
and you can
measuring.
get that
You're
feedback.
doing that already. You're already measuring. But
Yeah.
the isolated knee extension is the closest to the gold standard. It was a handheld dynamometer
Mhm.
under an orthopedic strap, right? Isometric, right? And that was so those were both a little bit what they ended up doing was overestimating the strength of the involved leg. Okay? So, for those 2 things, if you're doing it, you probably need to up your criteria for return to running, return to activity, da da da, da, to make sure that you're, accounting for that fudge factor.
Absolutely. So,
But you can
can
do
we
it with all of those things. You can, and there are some
So,
inline.
the one thing you can't do probably, and correct me if I'm wrong, the one thing you can't do is a handheld dynamometer with therapist force. It's gotta be fixed dynamometry, correct?
For the upper extremity, sure, you and I would get the same measurements because 'cause we're
Right,
both stronger than,
right.
their elbow flexion. But in the lower and you can get advantages testing the shoulder, mechanical advantages as a tester. But in the lower extremity, whichever one of us is stronger is gonna get the higher number.
Right.
So you're testing the strength of the therapist. Rehab
Not the
sessions,
strength of the patient.
not the strength of the patient. So we always do lower extremity with some like hip abduction. We'll have them, inside lying on the table, and we'll have a orthopedic strap, like a mobilization strap, with the handheld dynamometer between the strap in the leg, and we'll have them push against that where there's no way that they can overcome that.
Overcome. Yeah, they can't
And
overcome. Yeah.
so the same thing with quads. There's also a whole bunch of cool, you could buy a strain gauge, an inline
Mhm.
strain gauge,
Yeah.
and, put a eye screw into the side of one of your treatment tables, click in using those, like,
Carabiners.
bicycle
Yeah.
clips,
Yeah.
into a strain the 2 parts of the strain gauge, and then hook it onto a some kind of, connector.
And you just described
Oh,
a 40 to $50 setup, by the way.
maybe,
Yeah.
maybe, maybe,
Yeah.
and then you just have to stabilize the thighs. Again,
Right.
another strap will do that,
Right.
and you can make that chain as long as you want. If you want them to be isometric at 60 degrees, fine, let it play out a little bit more. If you want it to be isometric at 90, pretty easy to just have it down there. So, um, and you get numbers. I mean, they really are, and you can really address whether or not your your therapy's working,
So
your
let's talk
intervention.
about those numbers. So we need to know that our methods are working. Our methods are getting
Yes.
this essential measure back to normal because we know in the last episode we talked about how many functional things, knee osteoarthritis, all these kinds of things. If we don't get it back to normal, we're going to have problems long term and short term.
Well, let's put it this way: the stronger you could get them, the better they are.
Yeah. There's
Right.
just no doubt. And again, you just look at the aging research. If you wanna age well, have strong quads, right?
Mhm.
Have strong quads and
Yep.
glutes, right? That's pretty well what it comes down to. And so with that said, then as we look at those numbers, what are you looking at when you're let's see, we can even just do it from an isokinetic perspective. What are your key go-to, numbers that you wanna see?
All right. So we're a little bit different in our shop how we do this. We've studied neuromuscular inhibition, which is a good lead into um, activation failure, a good lead into STEM. But when we do our testing, I mean, when we do our testing to set like STEM goals, we do it volitionally. But when we're actually doing our testing, we actually do an isometric test on the electric mechanical dynamometer with a superimposed stem.
Mhm.
So they kick as hard as they can. We have some really fun videos of our staff screaming at the patients, and the they get up to a plateau, and there's a superimposed supramaximal 10 millisecond
Mhm.
simulation, and you can calculate the difference between the peak after that and the peak volitional and see what percent activation failure they have, because
So
we are targeting that as well.
that's awesome. So when you look at that, what number would you put on that you're seeing you want that difference to be
Oh,
under?
I want it to be gone, really. I mean, let's say normally, like if I were exercising and then I came in and did a test, let's say, you know, 10%, right? Because there are lots of reasons. They're tired. Our students, they had an exam the day before, they had a game the day before. But what we don't want to see are these big activation deficits.
That's awesome. So but then beyond that, if we're not using eStim with our isokinetic testing, what numbers do you look at?
It depends on where they are in recovery. So we have these our practice guidelines for lots and lots of different um, pathologies are on our udel.edu PT clinic website under the tab that says rehab professionals. You'll look at practice guidelines and you'll see by joint the different things that we have investigated and how we've updated them. Again, if you go to the ACL ones, they're recent and they're uh, b- f- uh, based on our population
Mhm.
over the years. It's a great thing to look at and see, but it depends on where you are. I mean, you're not gonna expect we have expectations of where they're gonna get, and then we
Sure.
have
Well, let's start with the end. Where do you want them? What
I
numbers
want
do
them
you
as
want?
close to 100% as possible,
Good.
right?
That's music to my ears because you know what normal is? As close to
What?
100% as
Yeah.
possible. Like, normal is not 90%, by the way,
No.
just in case anybody's wondering.
No, but people mostly, when you're using the return to activity, not necessarily return to participation, right? You've gotta get them into that, so we would transfer them to over to our colleagues. We have, athletic trainers and strength and conditioning coaches for our athletes. Um, we also have a director of rehabilitation for the, Department of Athletic Studies, our employee as well.
Nice.
And so there's a lot of and our residents coach do a lot of work over there. So we need to move them toward that on-field rehabilitation, really,
Mhm,
right? And so probably won't do that before they have 80% strength.
mhm. Sure. So you look at symmetry,
Mhm.
torque symmetry and things like that. What about, the relationship to body weight or norms or anything like that?
Those are different normalization um, procedures. They're good statistically, but the idea that there should be think about the different. You take care of athletes, so we
Right.
both do, right? So baseball players, high jumpers, figure skaters, uh, football players, just keep going, right?
Yes.
Should have the same ratio of peak torque to body weight.
Right, yeah, and there's
That
no
make
way well,
any
I
sense
mean,
to
we
you?
see that in the Y balance test. I mean, we
Sure.
know that a high school basketball player scores differently than a professional soccer player.
Sure.
They do.
Yeah. No,
But it
but
still gives
also
us some information.
it's
Right.
a normalization, right?
Right.
So if I'm doing raw, whatever, normalize to their body weight, the denominator is the same. So when you compare it, it goes away. It's the same as just, right?
Right.
Their body weight is the same.
Right.
So you can argue this as much as you want, but you're just measure the torque or the force or how many pounds they can lift. It's not you want to put body weight as a denominator on both sides, you're going to get the same percentage.
I guess the only way you would put body weight on both sides that would make that meaningful and not just another not just another, static factor would be you would have to compare to population norms.
No, exactly. So there are different things. It's like talking about MCIDs, right?
Mhm.
Minimal clinical important differences. When you calculate those in a study, those are for populations, not for an individual person in your clinic,
Right.
right? So you got to be careful about those things that are for population statistics versus I can directly translate this into my clinic and say, if he didn't gain 10 pounds of this in 4 weeks, he hasn't met that.
Right.
He might as well. He may not have done anything, right? So,
Well,
got
that's the difference between that's the difference between the error of the measure and the MCID, right? Because if we're not hitting the error of the measure, then we don't know, but that's a different number, and I think people
yeah.
interchange the 2.
And they're not, those are not statistics that are designed for application to an individual patient in front of you in your clinic.
Right.
They are population measures that you can use to inform your decision making, but not to say this person didn't do this in this time period, so they didn't improve.
Absolutely. No, that makes a ton of sense. So you mentioned activation failure
Sure.
and the use of electrical stimulation. Now, I will say you and I have both been around long enough in the in rehabilitation to know that modalities have maybe gone from a large part of the practice to a small part of the practice, and I think in general that's a really good thing, and I think it's awesome. But I don't necessarily think so when it comes to arthrogenic insult
Mhm.
that getting that quad firing again. Talk to me about the research in that area.
Sure. I mean, what we really needed to get rid of is all the. It's funny because it's like get rid of the you know hot packs, ultrasound, and massage, right?
Right.
Part, but there is a huge body of evidence supporting the use of neuromuscular electrical stimulation
Mhm.
for strengthening, functional electrical stimulation for restoration of more normal movement patterns, and for electrical stimulation for pain control. Huge body of literature. They're
Right.
not the same as throwing a hot pack on somebody.
Or yeah, or just yeah, doing an ultrasound or an iontophoresis and hoping and praying it works.
I would also say we've jumped on some new ones like dry needling,
Right.
right? So,
So talk to me about the import. So
or
yeah,
shockwave or BFR.
right. So talk to me about the importance of electrical stimulation in what the research tells us about electrical stimulation after a joint injury where the quad is being shut down. And we can all think about what that means, right? I kind of gave a general description, but whether it's ACL reconstruction or a meniscectomy or some sort of articular lesion that causes a good amount of bone damage or whatever. What Tell us the importance of e-stim there.
So, certainly, um, when you have activation failure or inhibition, I mean, we have to go back to neurophysiology, so I don't wanna be too neuromuscular physiology. I don't wanna
Let's hit it.
go too crazy here, but, um, when the we are volitionally activating our muscles, right? So, alpha motor neurons going down, let's say, to activate the quads. The smaller diameter nerves, innervate the slower twitch muscle fibers. Um, and it's called the size principle, which you guys all probably learned in school, where it's smallest to largest, right? So you have, and I like to think of those as low and high threshold motor units. Okay. So what happens is, with the neuromuscular, with inhibition or activation failure, those higher threshold motor units don't get activated. So volitional activation is smallest to largest, slowest to fast, right? So the highest threshold motor units are these faster twitch motor units. Electrical stimulation. So let me step back and say something very not controversial, but very true. Nerves are dumb. They're
Right.
they're in the periphery. They're just wires. So you put an electrode on your thigh and turn up the juice. It's going to send action potentials the way you want it to toward the muscle to activate it, and it's gonna send activation it's gonna send action potentials back toward the spinal cord, right? Both directions.
Right.
Antidromic, orthodromic, and antidromic. Um, so it also that is just resistance, right? So if you look at, a cross section of the nerve fibers that are flying down your thigh, the the lowest resistance is in the largest diameter fibers. Which is the opposite of, it is not as absolute as volitional, right? Which is always smallest to largest size principle. In about electrical fields, right? So you could have uh large diameter fibers. If you put large and small diameter fibers in a line underneath your skin, right? It would go exactly the reverse, largest to smallest, right? But that's not how they're organized. So you have some smaller diameter fibers closer to the electrodes will get activated before larger diameter fibers deeper from the surface, okay? So it's not the exact opposite, but you have a bias toward those fibers that are for our volitional contraction, the ones that are higher hardest to activate, right? So it targets that deficit. So it's a perfect.
So it's hitting exactly it's able to stimulate what stimulation does electrically or mechanically, there it causes exactly the nerves that are inhibited most to fire easiest. Is that what you're saying?
Yeah, it's the ones that don't get fired, right? Yeah, exactly, and so those hit. So, and think about, there's some really great research coming out of University of Kentucky, Brian Noren's lab, um, where they've actually shown that that these these motor units that haven't been activated start to behave like they're denervated because they're not getting any. So you actually see sprouting from other motor neurons to those motor units. So you get these giant motor units, you get all the stuff that you see in denervation because it goes on long enough. They're not getting a signal. We know what muscle does when it's denervated, right? It sends potentials out like nerve,
Right.
nerve, come innervate me, come here, right? Um, you can you can obviate that with STEM, right?
So
You're going to
so
get
let,
those.
let's pause there for a second because I think that's
Yeah,
a very important point there that let me give you an argument here is my athlete, my patient can do a volitional contraction. Why do I need stim? You're saying something there, I think that is important. You know, if I yes, I can get a quad contraction, but am I getting everything stimulated? And as a matter of fact, am I potentially reinforcing some of these the sprouting to occur?
yeah,
Um,
yeah.
is that fair?
Yeah, it's fair enough. I mean, I just think that we're going to segue right back in to measurement, right? If you're not measuring, you think it looks great. This quad looks great. Measure it,
Right.
right? If it is, great.
So you would say that
You
so you
start
would
right away.
say then if we're at 80, 90%, we've probably restored
You probably
normal. Now,
won.
I'm not saying we're back
Exactly.
to normal, but we can probably get away from needing to do some electrical
Yeah,
stimulation.
we usually do stim till they're 80%.
Yeah, because you now know you have enough nerves that are firing in the way they should be
Yeah,
firing that
and
now
that
it truly is.
they're probably recruited through the so large muscles, right? So we have two mechanisms that we use like in our brains to recruit more force. Rate coding, which is the firing rate, and recruitment, which is that smallest to largest recruitment of these different motor units. Um, in small muscles, uh, smaller than biceps and smaller, they recruit through about 50% of their MEs of their max, and the rest of their control is through rate coding. They
Okay.
increase the force and decrease it because if you can imagine, recruitment looks like this. You go up, you recruit another motor unit, and it goes up, right? That's not good for fine motor control. So the rest of the recruitment that the rest of the increase in force generation that happens in these smaller muscles is through rate coding. So you increase the firing rate. It's more like this than ding. But in the larger muscles, deltoid and larger, they recruit through the entire range of force generation, right? So them getting to those last ones is really hard. So how can we help them do that? We know it's a problem with quads for sure. Um, so we start STEM first day. We do it pre-op, we do it post-op, and we wrote a paper. We've had two Who's Afraid of papers in JOSPT, Who's Afraid of The Big Bad Wolf, which was about open chain exercise after ACL. That was me and Brian Noren. And then the Who's Afraid of Electrical Stim, which also has all we asked manufacturers for their units to test them and see if they have enough juice to be able to do what we want to do. And we have a video that goes with it that's also on our website. But we want it to be very instructive for clinicians. So it's super interesting to see what we can do. But we start them. We do uh, s- max stimulation, and the way that we deliver our stem in the clinic is we have the patients in the dynamometer
Mhm.
with the dynamometer set up, so we're measuring force, and we do an MVIC, and get what they've got, and then we wanna get at least 50% of that electrically. We do not superimpose it on the contraction,
Okay.
okay? So, as we wanna see that they get that 50% dose. We know that, 50% is, the minimum to be able to see strength gains from this, and more is better is what we know also. So it actually changes the conversation with your patients, Phil. So
In what
instead of
way?
say well, instead of saying, "Tell me when you can't stand this anymore,"
Mhm.
which sometimes is when they see you touch the dial,
Right.
right? To, "This is, the degree that this is what we need to get you to, what we need to get to be able to have an effect, to fix or help you recover your quad strength." Different goal. So then what you ask them is, "What can I do to help you tolerate what will be an uncomfortable level of contraction?" So, that's a different conversation than, "Tell me when to stop," right? You're telling them where you're going, why you need to go there, and asking them for their so
Yeah, so that
yeah,
you're actually incorporating all of the, research in patient dynamics, with that as a partner in rehabilitation and things like that.
yeah,
What do you find people say in that? What
I
are the
mean,
things that they
so
can use?
you were informed by this, Tony DeLito's doctoral dissertation. He did, there's you know okay, who invented anesthesia? Dentists,
Right.
right?
Okay.
People had to have their their legs amputated in war, you know, bite the thing, give them something to drink, but, you could hold on to a sore tooth for a long time,
Mhm.
right? So, this scale was also developed by dentists. Um, we all fall somewhere on the scale. It's a scale of blunters to monitors, right? So so blunters are people who are like, Just give me the headphones and laugh and gas," right?
Right.
And the monitors, we all know those we're mostly those people, is they wanna know exactly what you're gonna do, what everything means, when you're gonna how you're gonna turn it up, what it's gonna look like, blah, blah,
Right.
blah, 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 right?
Right.
We all fall somewhere in between. I mean, people fall somewhere in that range, but then you can that's the conversation to have. So I always tell my students when I talk about this, if you're a monitor, Lamaze isn't gonna work, right?
Right.
Distraction doesn't work.
Ah,
For blunters, you got the the more blunters they are, the more it's like headphones, laughing gets distraction. The monitors, they wanna see what you're doing. So if your goal is to get them to a therapeutic dose, which is what our goal is, it is our shared goal with the patients. You say, "This is where we wanna go. How can I help you get there?" Not, "Tell me when it's too much."
I love it. Yeah, like, totally different conversation. That
Totally
is
different conversation.
that's awesome. That's an incredible insight. Now, let's talk about the research for anybody that, okay, we've made a very good physiological case for using neuromuscular electrical
Mhm.
stimulation. But tell me about the research in the strength gains when you compare using it versus not, and I think that's
Where do you want me to go back?
well, let's just hit it. Let's give us
Well, I
the
mean,
50,000-foot view.
my doctoral dissertation, which was, late '80s, um, and going forward, first big multi-center study that was funded with, Susan Strelka at the Campbell Clinic and Tony Toledo, who was then at WashU. Um, there is a stim volitional exercise alone and volitional exercise plus stim. There's a significant added benefit of adding stim, and nothing has changed about that over the ensuing decades, really. So, um, you Tony Kelly Fitzgerald, who was another former doctoral student of mine who was a professor at Pitt for a really long time. Kelly said, well, let's see if I can, for people who don't have dynamometers, and let's see if, so it did like people do, where the patients are on a treatment table, right, in long sitting, and do the contraction do
Mhm.
the stim that way. Again, not superimposed on a contraction. This is not functional electrical stimulation. It's just trying to hit those motor units that you can't hit volitionally. Um, and he decided, as one of the factors, he thought, well, maybe people who have a lag may benefit more
Mhm.
than the people who don't, which in the end didn't work out. But he found the same stuff that we did, right? Where adding the stim was way better than not adding the stim. And that the strength gains overall were not as good as they are with the, what he called this high intensity protocol that we did in the dynamometer. Okay. So, I mean, it just keep going. It's just, there's not like, nothing's changed physiologically in people since then. Right.
I think you made a really good distinction there that, while we have you have the person set up in the ice in the dynamometer, in the
Right.
isokinetic or isometric dynamometer, but you're using that for measurement to determine the level of E-stim we should get to. You're
Mhm.
not having them do a volitional contraction in that unit.
No. No, when we're doing NMES for strengthening versus functional electrical stimulation, where let's say the probably the earliest use of that was a dorsiflexion assist in stroke, right?
Mhm.
Right, where you're helping them do something. Um, we use that a lot in also in our orthopedic and sports physical therapy to help people in get enough force for their movement to make the movement more natural or more normal. But when you're strengthening, you've got those competing, not competing, but opposite recruitment things that are going on. And what you don't want is for them to collide, which, if remember the dumb nerve that you put the electrodes on, is sending potentials back toward the brain that can collide with the ones that are coming down. Right. So they won't activate. Right, it's an interesting conundrum, but it's different therapeutically. Your goal with the neuromuscular electrical stimulation for strengthening is to get those motor units that you are not activating volitionally. And sometimes just activating them at a higher level. Again, it's when you think about it, we set our frequency, we end up with a synchronous, right? All the motor units contracting in the at the same time, right? Um, so we do not superimpose it
No superimposed
for
volitional.
strengthening.
For strengthening.
Right.
Right,
But
for functional
yeah.
electrical stimulation, and that is a distinction. That is a difference. That's an important difference there. Can you take us through, maybe a patient example that would apply all the information that we went through, and maybe even do it from a perspective of, I don't necessarily, have an isokinetic dynamometer in my clinic. Maybe
Mhm.
I have a strain gauge or,
Yeah.
that type of thing. Can you walk
Handheld
me through what
dynamometer.
that would look like?
Yeah, I mean, we would put them in a position that, whatever, we typically put them in 90 degrees, and or what, depending on how much flexion they have when they first start out. You could do the same thing with your, with the strain gauge or with a handheld dynamometer and a strap, right? All of those will work. And you test side to side what their strength is. And then your first shot is to try and get at least 50%, and to, again, negotiate that, help your patients understand why that's our therapeutic goal. And again, how do I get you there? But early on, a good example, and it's very common. So you have a patient who's coming in, it's their first day after surgery or a couple days, or maybe unfortunately they didn't get to you for a while.
Yeah.
And so they're swollen and they're stiff. Um, we getting that muscle going again is really critical. And you can do it just, again, sitting on the table like Kelly Fitzgerald's paper showed. But when you measure, when we measure, so a patient like that comes in and we measure, they might have barely anything,
Right.
20%, 30%. Their first contraction electrically is gonna be higher than that. It's not gonna be 50%, it's gonna be 150%, right? Because
Right.
they don't they're and it's funny because often that first treatment wakes up that muscle.
Enough
So
to get it.
their volitional contraction when we test them after that is way higher, clearly not atrophy, right? We're talking about activation. So that's a really cool pearl, right? Get them it can help them overcome that, or at least remember, like, when the muscle is stimulated, all the afferents still go back to the brain. The brain sees a contraction of that
Yeah.
muscle, right?
And so we're probably causing the mapping of the brain to not change as dramatically, after that.
Potentially,
If we can g
yeah,
if we can keep that pipeline
that's
going.
correct. If you can't keep that was back to Dusty Grimm's students' work.
Yeah,
Yes,
that's
yes,
awesome.
probably. But it's a very powerful tool. Um So again, I'll throw you to both our udel.edu PT clinic
Mhm.
website on the AE-STEM and to the JOSPT article and the video, which are in both places, um, to talk about the actual logistics.
Right.
One of the biggest mistakes, I have to say this for E-STEM, biggest mistakes that people make is they use these little electrodes. You need big electrodes, like 4 by 6, roughly.
Well, because that helps with, I would imagine, a couple different things, both the tolerance and the amount of magnitude of stimulation. Is that correct?
Yeah, both. I mean, so we put the distal pad, central medial
Okay.
on the quad and the, um, proximal pad central lateral, and that electrical field touches all 4 motor points of the quads. So which is what you want. You want the field to hit all 4 motor points of the quads, and it does. But all those little ones, there's so much current density and sort of superficial level intolerance to just the sense of electricity. It's and it doesn't get the job done. So,
Right. Absolutely. Well, that makes a ton of sense. Well, this is this has really flown by. With that said, so you talked about size of electrodes. Like, man, if you could give a tip out there using the largest electrodes, possible
yeah,
there,
but not
and
well, I'm sure there are, like, gigantic back
yeah,
ones.
I imagine there are some that are
Yeah.
yeah, we don't
I
want
think we
we're
actually
not
gave
doing 6 inch by 20
we gave
inch.
the dimensions of the ones that we typically
That's
use.
fantastic. We'll include those in a resource too.
Yep.
So that's a big tip. What other are the key takeaways that you want people to know walking away from this episode? So we, what other key takeaways are there for you?
Figure out a way to measure your quad strength. There's lots of different ways to do it, and if you don't have any of those devices, you probably shouldn't be treating ACLs, right? I mean, if you don't have
Right.
a knee extension machine, everybody should have one, and
Right.
cable.
Well, and I don't have a lot of, I work out of my own, actually little performance center outside of my a detached garage. But one of the things I don't use a lot of equipment, but one of the key things I have is a knee extension and knee flexion machine because and I will tell you, you can get them very inexpensively now and some really good quality ones. Before they were thousands of dollars.
We
Now
we
they're literally just a couple $100.
if you're in the market, we've got a bunch of our Isoconnect dynamometers for free. People were closing, they didn't,
Wow.
they didn't wanna have
Yeah.
it anymore. We have this guy who
They don't
will
like the footprint it takes up and
they'll refurbish it for you. So, we paid them to move it and refurbish it. That was it.
that's awesome. That's incredible. Okay, so find a way to test quad strength. What else?
Um, Reconfigure your therapeutic brain in terms of neuromuscular stimulation to we have to get a certain level of contraction force, electrically elicited force, and get your patients to understand that and help them figure out how to get them to tolerate, again, what will be, not might be, uh, an uncomfortable level of current.
That's awesome for sure, and that's, I love the way you talk about that, and the different personality types that really
Mm,
can impact that, and maybe that's something that we learn as we go on, but we don't have a name for it. But having those names really causes us to be able to say, "Oh wow, yeah,
yeah,
I've
I
got a
can
monitor on my
yeah,
hands. I better give them information." I'm the type of person. I had a knee surgery a couple years ago. My kids were amazed. I'm like, If I could be awake during it, absolutely, I wanna
would've.
watch every
Yeah,
single every
yep.
single part of it. That would be amazing, and maybe I might give them a few tips along the way. Uh, but so
Laughing gas, but headphones are good sometimes. Bring your music, whatever you need to distract yourself for those people who are more on that end of the spectrum.
absolutely. Well, that's for sure. Those are big, big takeaways there. So as we kind of wrap up here, tell us, what you're currently working on.
So I retired from the university as a professor in 2022. I still have we just in the fall finished up our our Delaware also cohort grant, which is 20 years. We published our 10-year results in JBJS late December of 24. I'm working with uh, Brian Noren at the University of Kentucky and his graduate students on the stuff that they're doing, which is super fascinating. And just collaborating with my national and international colleagues, doing lecturing, and also enjoying my grandchildren, which is really fun.
Oh, that's so fantastic. That is great. We appreciate all the contributions that you've given, to our professions, and, it certainly is appreciated, and I wanna take this opportunity, to thank one of my, distant mentors, for all that, so I appreciate that. How can people connect with you?
So my email is smack@udel.edu, which you guys can put up there, but it's also go to the if you can't get it, go to the University of Delaware website and go to the directory. They will not let you find students, but they will let you find faculty. And I have X threads. This guy I'm at Doc L Smack. I think I sent that with the and again, send me a message. But email's the easiest to if you really have questions, right? Because it's easier to attach things and
Sure.
direct you.
That's awesome. Well, I again, so much appreciate your time. Thank you so much for being on the episode.
You're welcome. Thanks for inviting me. It's been a blast.
Yeah, we've had a good time here. Well, fantastic. If you'd like to connect with me, you can find more information about what I'm doing, what I'm learning, what I'm up to at philplisky.com. And until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.